Great. So good afternoon or good morning, depending on where you might be joining us from, and welcome to our National Learning Series from the Population Health Task Force. We're going to go ahead and get started. We have a lot to get into today and a wonderful lineup of panelists to discuss today's topic, which is housing and HIV, how we bridge that gap between HIV outcomes and housing, particularly when we're talking about special and vulnerable populations. So let's dive on in. As I mentioned, this is our second session of our National Learning Series. If you didn't join us for our first session on March 6th, all of our materials are available on our website, which is pophealthtaskforce.org. Our next session will be on March 20th, where we're talking about diabetes prevention. And then our final session will wrap up on March 27th. As always, please familiarize yourself with some of the tools at the bottom with Zoom and for this webinar. And as I mentioned, this series is brought to you by the Population Health Management Task Force, which is a group of national training and technical assistance partners that's funded by the Health Resources and Services Administration Bureau of Primary Care. And we're here to provide training and technical assistance across a variety of topics. And today we're going to be talking about housing and HIV. So here's just a shout out to some of our Population Health Management Task Force members. Great. So what is an NTAP? As I mentioned, we are contracted with BIPIC to provide training and technical assistance resources to improve access to care and health outcomes among federally qualified health centers and primary care associations across the country. All of our materials and activities can be found on the Health Center Resource Clearinghouse, as well as the Population Health Task Force website. My name is Jamie Blackburn. I'm a senior program manager with Corporation for Supportive Housing on our federal technical assistance team. And I'm joined by our illustrious lineup of panelists for our conversation today on all things HIV and housing. And I'll let folks introduce themselves as we get to their section of the presentation. But in the interest of time, since we have so much to dive in, and I know that folks have good questions, so please bring your questions in the chat. We'll do our best as we go forward to answer them as we go. We will also try to save time at the end for some Q&A, but by all means, please introduce yourself in the chat and bring your questions. So for today, we're going to talk about why is housing such an important, or what we would say is the most important social driver of health. We're going to talk about the intersection of HIV prevention and linkage to care with housing. We're going to talk about that intersection of HIV and Hep C and special considerations for co-infection. We're going to talk about the importance of partnerships, cross-sector collaboration to advance HIV prevention and linkage to care. And then we're going to discuss some of the very specific funding streams and programs within housing that support people living with HIV. All right, so real quick, before we get started, would love to know from folks. I'm going to launch this. Let us know. Have you heard of the Health Center Excellence Framework? It's perfectly okay if you have not, but we us as a group, as NTAPs, would really like to know as a benchmark if folks have heard of this framework. So far, it's looking like the majority of folks have not heard of the Health Center Excellence Framework, and that's fine. Some of you have heard. That's great. Wonderful. Thank you to everyone who's taking a moment to respond. And again, thank you to everyone who's continuing to introduce themselves in the chat. Great. So the Health Center Excellence Framework was advanced by collectively amongst our group of national training and technical assistance partners as a way to advance health equity and identify strategies and domains where health centers can advance to improve health outcomes and health equity across some of these very specific domains. Today, we're going to be operating within that population health and social determinants of health domain. This framework was launched during COVID times, and it's not surprising that a lot of folks are less familiar with the framework, but it's our intention to continue to lift up its importance across all of our training and technical assistance work. And so we really encourage you to take a look at this, and we certainly will be providing more resources as a collective group of NTAPs around the framework going forward. So thank you all so much. Okay, so let's talk about housing, healthcare, and HIV. I always love to kick off a conversation around housing with this wonderful quote from Jack Geiger around, the last time I checked my textbooks, the specific therapy for malnutrition was in fact food. So recognizing the fact that housing really is healthcare. And so I always like to kick off this conversation with this quote because it really just hits home that sometimes the most basic solution that we need is access to housing, and that housing is the platform upon which positive health outcomes can be achieved. We know that it is one of the most basic and powerful social determinants, social drivers of health. We also know that higher cost burden upon patients can lead to negative health outcomes, and including and is linked to higher rates of HIV prevalence. And in recognition of housing as a platform and driver of health, the Healthy People 2030 objectives have aimed to reduce the percentage of families that are rent burdened. And when we say rent burdened or cost burdened, that means people that spend more than 30% of their total income on housing related expenses. We know that there is an ongoing affordable housing crisis in the United States. This should be unsurprising to most folks. Only about a quarter or less than a quarter of individuals that are eligible for assistance are actually able to access it. We know that the average wait time for access to common resources like public housing or housing choice vouchers is 2.5 to about 2.5 years, but that's only amongst folks that are actually housed. We know that it's actually much longer than that because of people that fall off of waiting lists. And over half of housing agencies across the country do not even have an open or active lottery or waiting list. Their waiting lists are actually closed. What can we learn about housing insecurity and homelessness from our UDS data? So we know that 94% of federally qualified health centers across the country are now screening for social determinants of health, capturing this data around homelessness and housing insecurity. About 1.2 million patients served, homeless patients served in FQHCs. Over 500,000 folks screened positive for housing insecurity in 2022. So this is the most recent released UDS data. 7.1 million patients screened for HIV, so about 43%. And about 5,900 patients, that's 82%, are seen within 30 days of a first diagnosis of HIV. This map shows where federally qualified health center patients that are screened positive for housing instability or identified as experiencing homelessness are located across the country. I think sometimes we tend to think that housing and homelessness is something that's concentrated in that homelessness and housing instability are issues that are concentrated in more urban areas, when really this is something that is pervasive across the United States in both rural, suburban, and urban communities. And when we talk about the link between housing and HIV outcomes, as this other graphic shows us here, that folks who have access to quality, stable, affordable housing are more likely to connect with and stay retained in HIV care and treatment. And so when we see these numbers of the number, patients that are experiencing housing instability and homelessness, and we know that broadly there's a crisis across the United States, it's even more imperative that we create the connections with our housing providers in our community to ensure that our most vulnerable patients, those that are at risk for HIV or living with HIV, can access those resources. So continuing in our theme, that their research continues to demonstrate that there is a significant link between stable housing and access to stable, affordable, quality housing and HIV outcomes. And we know from a lot of really good data collection that half of Americans living with HIV are going to experience homelessness or housing instability at some point. This wonderful graphic right here from a recently published study sort of outlines where there's unmet need for housing or shelter. So these are individuals that might not even have access to emergency shelter services or living in an unsheltered tent encampments. And we see this state by state breakdown of where the need is highest. And we see that many of the jurisdictions that are reporting the highest unmet needs for housing and shelter are concentrated in the southern portions of the United States. We also know that there's a link between housing insecurity and viral suppression levels. So this graph shows a breakdown of individuals that are Ryan White program participants, that those with stable housing have higher rates of viral suppression than subpopulations that do not have access to stable housing. So any conversation where we're talking about needs of individuals at risk or living with HIV, invariably, we also need to discuss the intersection and risk for co-infection with Hep C. One of the um, target populations and key target populations for HIV prevention in the United States, and one of the populations with that are most at risk are individuals who inject drugs, and they are also the highest proportion of individuals that are co-infected with HIV and Hep C. There's about 3.2 million individuals in the United States right now that are co-infected. And so these are something that, when we're thinking about interventions and linkages, that we have to think across all of the challenges that a particular patient might bring to the table and how we can provide those integrated services to comprehensively meet their needs. Unfortunately, we don't always see HIV and Hep C testing bundled together, offered in the same bundle of services. And so this is something that certainly bears looking into. So when we talk about housing resources for individuals living with HIV, supportive housing is certainly one of the primary housing and service models that can be used to support this particular population. Permanent supportive housing is deeply affordable housing that is made available with wraparound services that are targeted for the individual or family in need. It's typically aimed for individuals with multiple barriers, such as folks who have experienced chronic homelessness or other issues. Supportive housing can be single site, so where all units on a particular project, and there might be some units are permanent supportive housing mixed with regular affordable or market rate housing. It could be scattered site where there's subsidy attached to a particular unit, but they are not concentrated in one building. You might even see it in form of a master leasing situation where the services organization master leases the units and then subleases them to subsidy holders. So there's a variety of ways that permanent supportive housing may materialize in your particular community. There are pros and cons for both approaches, but it's important to inform yourself in your community as to what permanent supportive housing resources are available. We do know that research has showed that single site permanent supportive housing can be very beneficial for individuals with histories of homelessness, substance use disorder, or living with HIV/AIDS. So these are important considerations. But let's talk about the primary housing program and resource for individuals living with HIV in the United States is HOPWA. So HOPWA is administered by HUD, so that's the Federal Department of Housing and Urban Development, which then makes grants to local communities, states, or nonprofits for projects that benefit individuals that are living with HIV/AIDS and their families. It's targeted for folks that are at or below 80% area median income, so lower income. However, HOPWA is quite underfunded as a federal program. So 2 out of 5 individuals that are eligible for HOPWA are not able to receive it because of these budgetary constraints. And I do see some comments in the chat to that same effect, if only there were enough PSH for all of the people that need it, certainly. And we could espouse for days as to why our housing system in the United States is structured this way. The reason why it feels as though we are constantly in a shortage of the type of housing that is necessary to meet demand across the United States is because housing is not funded as an entitlement, unlike other parts of our social safety net, such as SNAP benefits or Medicaid, Medicare, and Social Security. I will drop this link in the chat for folks so that you can use the HUD resource locator tool to find who your point of contact is for your local HOPWA program. These screenshots will show you how the HUD search tool works so that you can find that contact person. It can be sometimes difficult at the local level to accurately identify who that point of contact is, but this is the best place to start. we'll go ahead and drop that in the chat. Other federally funded housing resources to stay informed on. HOPWA is the primary housing program in the United States that serves individuals living with HIV, but it is, as I mentioned, underfunded and will not always be able to meet the demand in a particular community. So it's very important to stay informed of what other housing resources are available to you. Our internal data shows that broadly across the United States, the majority of health centers are not deeply connected to the housing sector in their community. And so there's often a lack of knowledge on who their primary housing partners should be. And so in that same light, your HOPWA, when we're talking about folks living with HIV, HOPWA provider is your HOPWA provider is your number one contact. However, you should also be forming partnerships with your local public housing authority. Also, that they administer the housing choice vouchers, otherwise known as Section 8. There are Section 8 project-based vouchers, as well as your continuum of care resources. Your local COC, that's your continuum of care, is your homeless response system within your community. And that can take a number of different forms. It can be city-based, county-based. Sometimes we have statewide. So there are several states that have a single COC. So it's very important to familiarize yourself with who your housing partners are so that you can max out your connections to those existing resources. There are also state and local housing resources that you can tap into. These are a bit more of a patchwork, but there is a wonderful database that's maintained by the National Low Income Housing Coalition that I strongly encourage you to look at. It's the only database that I believe that exists that shows a comprehensive summary of every state and locally funded program that is available. Unfortunately, in the United States, the vast majority of housing resources come through the federal government, and a very limited number of states offer tenant-based rental assistance outside of federally funded resources. And of course, eligibility length and the amount of assistance will vary from state to state. A greater number of states offer emergency one-time or limited housing assistance programs, or perhaps offer tenant-based rental assistance subsidies for specific subpopulations. But this wonderful database maintained by the Low Income Housing Coalition can show you what is available in your particular area. Great. So I'm going to hand this over now to Dr. Kevin Ard to talk about the intersection of HIV and Hep C. Please keep your questions and comments coming, and I will be putting these links in the chat for you all to find your local housing partners.
Thank you so much. It's great to be here, everyone. My name is Kevin Ard. I'm an infectious disease doctor at Massachusetts General Hospital in Boston, and also the medical director of the National LGBTQIA Plus Health Education Center at the Fenway Institute. And it's my pleasure to talk a bit about this topic of the intersection of HIV and hepatitis C that Jamie mentioned in her comments. So these are really overlapping epidemics. Both HIV and hepatitis C can be chronic viral infections. They can have long asymptomatic phases, but then also the potential to cause severe illness and death. These infections are, of course, transmitted in similar ways. So, for example, percutaneous exposure, like injection drug use, and then also sexual exposure, although this is much more common for HIV than for hepatitis C. As Jamie mentioned, about 21% of people with HIV have current or prior hepatitis C, and that number is higher among people who inject drugs, going up to around 80%. And that co-infection with these viruses, with HIV in particular, does accelerate liver damage from hepatitis C. Many of you may be aware that about 10 years ago now or so, the number of deaths attributed to hepatitis C rose above the number of deaths attributed to HIV. And that's shown in the figure on the left-hand side of this slide. And this trend has continued. So for example, in 2021, there were nearly 14,000 hepatitis C-related deaths and just under 5,000 HIV-related deaths in the United States. So I'm going to share a case that I think illustrates how these infections may co-occur. This is a 32-year-old man who has HIV and presents for a routine follow-up visit. This patient is doing well on antiretroviral therapy with a common regimen that's used for first-line treatment. Laboratory testing at that visit shows that the HIV viral load was suppressed, which is the goal of therapy with HIV treatment. The CD4 count was normal, but there were new elevations in some of the liver enzymes, the ALT and the AST. And some additional testing showed that the hepatitis C antibody was positive and the hepatitis C RNA or viral load was nearly 4 million. This person was surprised and was not sure how he could have acquired hepatitis C, but he did report occasionally injecting methamphetamines and also reported condomless anal sex with other men, and also sometimes engaged in oral anal and digital anal sexual practices. His additional testing showed that he had hepatitis C genotype 1A, which is very common, and no evidence of hepatic fibrosis yet. So this case raises some questions. What are the recommended approaches to screening for hepatitis C among people with HIV? And then what are important considerations for hepatitis C in the setting of HIV co-infection and or in the setting of ongoing injection drug use? We know that HIV incidence has been rising in some populations, and one of those would be men who have sex with men, or MSM, both those who have and who don't have HIV. The graph on the left-hand side of the slide shows HIV incidence over time among men with HIV, and I should say hepatitis C incidence. Hepatitis C incidence is associated with condomless anal sex, with sexual practices causing bleeding, and also with methamphetamine use. But there's also a rise in hepatitis C infections among men who have sex with men who don't have HIV. And this is highest among those who are taking PrEP. And that's shown in the figure on the right-hand side of the slide. As you likely know, hepatitis C screening is recommended for all people who are aged 18 years of age or older in the US. But it's also recommended in other circumstances for people who have HIV or people who have a higher likelihood of acquiring HIV. So for example, we do this upon initiation of HIV care, and then also yearly thereafter for men who have sex with men. It should also be performed when people start PrEP or pre-exposure prophylaxis for HIV, and then at least annually thereafter among MSM and transgender women and people who inject drugs. And in general, the screening strategy is to first do a hepatitis C antibody if they have no known history of prior hepatitis C, and then a hepatitis C RNA if the antibody is positive. When people have HIV and also have hepatitis C, you can absolutely effectively treat the hepatitis C. Hepatitis C treatment is effective among people with HIV. The one thing to think about are some drug interactions that can occur between antiretrovirals for HIV and the medications used for hepatitis C. But these are nearly universally manageable. And there are some great resources and guidance from the National Hepatitis C Guidelines. Here's one example of that shown there that can help you select a regimen for hepatitis C treatment in your patient with HIV, or help select an HIV regimen that does not interact with their hepatitis C treatment. I also want to emphasize the point that active or recent drug use or a concern for reinfection related to drug use is not a contraindication to hepatitis C treatment. And that line comes directly from the National Hepatitis C Guidelines. And what is the rationale for that recommendation? Well, rates of sustained virologic response are high among people who inject drugs who receive hepatitis C treatment. So even though they may continue to use drugs, that the rates of reinfection are still not high in that scenario. Reinfection will, of course, occur, as with many other infectious diseases. But the overall rate is low, as I mentioned. It's 1 to 5 per 100 person years among people who've ever injected drugs. And there are also modeling studies suggesting that there are public health benefits to treating people who inject drugs because they are then less likely to pass the infection on to others. So hepatitis C treatment for people who are actively using drugs has both personal benefits for them in terms of their health and also public health benefits as well. I seem to have lost the ability to advance the slide. But I can just, I guess, speak without my slides for the next couple of minutes because I don't see them up on the screen anymore. Not sure if others do.
We will work on getting those back.
Okay,
let's see what we can do.
Well, we're working on that. I'll just make a few other comments. One is that for follow-up for the patient case that I presented, there was the opportunity for kind of a clinic protocol that facilitated hepatitis C treatment for people with HIV. And so this consisted of a protocolized set of baseline laboratory studies, counseling with a nurse about the medication, the importance of adherence, and potential side effects of the medication, and then some case management to help with any prior authorizations that were required. And with that, the patient was able to be started on treatment, completed the treatment, and achieved and has maintained a sustained virologic response despite ongoing intermittent injection drug use. And so in summary from this segment on HIV and hepatitis C co-infection, I just want to emphasize, and I'll kind of advance to my final slide here. Whoops. That HIV and hepatitis C share risk factors. Many people with or at risk for HIV are also at risk for hepatitis C. That it's recommended to screen for hepatitis C upon initiation of HIV care or PrEP, and then MSM with HIV should be screened at least yearly according to our national guidelines. Hepatitis C treatment is compatible with antiretroviral therapy for HIV and PrEP, but it's important to be mindful of drug interactions. Those are manageable in general. And then people with active injection drug use and hepatitis C should be offered hepatitis C treatment, and this is a component of our national guidelines for the treatment of hepatitis C. And so with that, I will turn things over to my colleague, Kristen Lasko, to talk about HIV and housing and the example from Fenway Health.
I do want to just give one moment to acknowledge a question that we had in the chat about housing options for individuals living with Hep C. I think it's important to highlight before Kristen starts her part of the presentation to address this question is that no, there is no federal program for Hep C that is equivalent to HOPWA for individuals living with Hep C, despite, as Kevin just mentioned, that we finally reached that point where there's actually more deaths attributed to Hep C than there were at HIV on that graph that he presented. And so I would say the nearest equivalent resource that would probably be a really good intervention for individuals living with Hep C would be permanent supportive housing. Why? Because individuals living with Hep C co-infection are highly likely to have other challenges such as substance use disorder, perhaps co-infection with HIV, or experienced chronic homelessness or housing instability. If they have other risk factors in addition to their hepatitis C, permanent supportive housing would be an excellent resource for that individual, and you would access that resource either through partnerships with your public housing authority or your local continuum of care. And with that, I'll hand it over to Kristen.
Okay, I'm up. Hello, everyone. Good to be with you. My name is Kristen Lasko. I use the she series pronouns, and I'm the Director of Housing Services for Fenway Health in Boston. Okay. There we go. Okay, so just briefly to set the stage, I'm here to hopefully use our experience at Fenway to illustrate an example of bringing some housing services into a health center model and bringing all of that together to support our clients and patients living with HIV. So at Fenway, our mission is to advocate for and deliver innovative, equitable, accessible healthcare, supportive services, and transformative research and education. We center LGBTQIA+ people of color, and other underserved communities to enable our local, national, and global neighbors to flourish. And we really see our mission as reaching both the Boston area, the nation, and hopefully beyond that as well. Fenway is a federally qualified health center. We are a longtime recipient of Ryan White funds, parts A, B, and C. And we're the largest non-hospital provider of HIV medical and behavioral health services in Massachusetts. One thing to highlight that's important to our model is our community health worker program, which is specifically designed to support patients living with HIV, maybe outreach to recent patients who have not engaged recently, and to make sure that any and all of our patients living with HIV have access to the social determinants of health services and care that they need. All right. I often introduce myself as being from Fenway Health / AIDS Action. And that is, I will explain what the connection is now. So AIDS Action used to be a standalone AIDS service organization. We were the oldest and largest ASO in New England. And in 2018, Fenway Health and AIDS Action merged together after a 5-year strategic partnership. So AIDS Action is now the public health division at Fenway. And the services that we provide as the public health division are housing prevention programs, including drug user health and sexual health, our community health worker program, legal services, and our youth-focused programming at Youth on Fire. All right, so within the housing department, we serve households living in Massachusetts where at least one household member is living with HIV and those who meet the low income guidelines. And I left this generally a little bit vague because in some cases, as Jamie mentioned with HOPWA, we're looking at an 80% area median income guideline. As many of you, I'm sure, know, for Ryan White, we're looking at a 500% federal poverty level guideline. So it's a little bit of a combination of things going on. Our program areas in the housing department include housing search and navigation, helping our clients to access a lot of the resources that Jamie mentioned in her presentation, supportive housing and stabilization, and rental assistance. So I'll get into a little bit more detail of those program areas in just a moment. In general, we have an operating budget for the housing department, specifically of over $4 million a year. We have 5 different funders, but you'll see in a minute that this breaks out into many more budgets than that number might indicate. Okay, so some things to hopefully set the stage in a helpful way about the housing department and really our public health program largely in general, is that we are serving clients who are Fenway patients, and we're also serving a lot of people who are living with HIV who receive their care at other clinical sites, hospitals, et cetera, anywhere in Massachusetts. We are blessed with a wealth of different medical providers and settings in this area. So we really work with a lot of people who get their care outside of Fenway, and that's great. So we, because of that, we rely on partnerships with dozens of health centers, hospitals, and community organizations across Massachusetts. We work with them to sign MOAs so that there's an agreement around what services we are able to provide, what support we're looking for from the case manager or advocate making the referral, and make sure that the client is getting the wraparound services and care that they need. So for a lot of our programming, case managers and advocates, both within Fenway and externally, are identifying the client's need for rental assistance, for housing search, for any housing related support, and making those referrals to our programs. All right, so within the housing department, we're looking at 2 main program areas: housing support, where we're doing a lot of search, advocacy. A lot of clients are denied housing opportunities because of things in their background, and so we're working to appeal those denials and hopefully mitigate some of that background. We work with a lot of people, unfortunately, who are facing eviction. And so we work very closely with our legal services program internally to support those folks and try to either retain their current housing or help them transition as smoothly as possible to another housing opportunity. So our housing support program is about 400 households annually. And then we have rental assistance. And this is financial assistance. This is checks out the door to landlords, to utility companies. The vast majority is for short-term assistance, security deposits, rental arrears, oil, payments, things along those lines. And for a relatively small number of households, we're providing tenant-based rental assistance. So we're paying a portion of the rent on a monthly basis for a long period of time in some cases. And that rental assistance program is about 450 households each year. All right, so I'm going to break down, how do we pay for all of this? So this is an overview, and then I'm going to get into a little bit more detail in the subsequent slides. So our biggest funder is the Massachusetts Department of Public Health, and the funding that we receive from them for our housing services is a combination of Ryan White Part B dollars and then state dollars. So obviously, we are extremely privileged in Massachusetts to have state level support and have that be a significant part of our budget. We also receive HOPWA money from a bunch of different places. So the city of Boston, the city of Cambridge, which is adjacent to Boston, directly from the Department of Housing and Urban Development, and also directly from HUD through a short-term program called HEPA, Housing as an Intervention to Fight AIDS. In addition, we receive some housing support from our local Ryan White Part A administrator, which is the Boston Public Health Commission. Okay, so a little bit more detail. Massachusetts Department of Public Health provides support both with housing search and so that's staff time basically, and rental assistance, which is mostly money out the door, a little bit of staff time. Our Ryan White Part A money also is split between our housing search efforts, our rental assistance efforts, and then we also receive a very modest amount of emergency financial assistance, which is a separate category and allows us to do things like pay for movers, maybe pay for a utility debt from a previous address, kind of fill those gaps a little bit. It is Part A money, so there's a pretty prescribed list of what you can and can't do with it, but it has been a pretty effective gap filler once you kind of figure out how to use it. Okay. All right, so HOPWA. So Jamie gave a great foundational overview. And so from a program perspective, kind of on the ground, we're piecing together HOPWA money from a bunch of different places for our programming. So the city of Boston receives formula HOPWA funds to cover 3 counties locally. For our purposes, we use it for housing search, which is that HIS category, supportive services for our supportive housing clients, and then permanent housing placement, which is startup costs generally, and short-term rental, mortgage, and utility assistance. I know it's pronounced very differently across the country. I say STROMU. I'm sure some of you are outraged right now, but we receive that money from the city of Boston as the administering agency for those 3 counties. For another 2 counties locally, we receive HOPWA money from the city of Cambridge. So same sort of thing. In this case, it's tenant-based rental assistance, supportive services, PHP, and STROMU. And then there's a portion of the HOPWA money nationally that is allocated not through the formula of need, but through a competitive process. And so we have a long-standing competitive HOPWA grant where we're providing tenant-based rental assistance to households, the supportive services, and the housing search that they need to inevitably relocate as they remain in the program over time. And then we're kind of in the middle of our HEPA grant, which is a special project of national significance. And the driving force of this program, some of you out there may be involved with it as well, is to really bring that connection between the health outcomes and housing stability. And we're really looking to serve people both who have a housing need, a pressing housing need, and who are not well engaged in care. Okay, so to highlight hopefully how we bring some of our different funding sources together, we'll use the rental assistance programs, which is our financial assistance, as an example. So for this program, we are using Massachusetts Department of Public Health funding. We're using HOPWA money from the city of Boston. We're using HOPWA money from the city of Cambridge, and we're using housing assistance money from Part A Boston Public Health Commission. So there's some overlapping geography there. Again, we're very fortunate that DPH can cover the entirety of Massachusetts. So we're able to piece these different funding sources together and meet our goal of maintaining a cohesive program where we have one set of eligibility criteria and a single application, whether you're in the western part of our state, you're out on Cape Cod, wherever. You're filling out the same application for rental assistance through our program. And we also ensure that we're gathering the information and verifications that we need to satisfy any of our funders. And so from there, once we determine eligibility, we can piece together and say, okay, this, HOPWA can cover the security deposit and Ryan White can cover a first month's rent payment, and kind of put the different funding sources together to meet the whole financial assistance need for that particular client. Okay, this is by no means an exhaustive list, but if you are in the process of trying to build up programming similar to what I'm describing here, these are some resources and other areas to kind of keep in mind and try to build up. So Jamie mentioned COC, so I won't get into that in detail. There are other rental assistance sources out there. For example, other agencies in the Boston area also receive Part A housing assistance money. So we're never going to overlap, of course, and pay for the same things, but we can coordinate with our colleagues at other agencies and say, okay, we can pay this person's back rent, you can pay some months of ongoing, and then therefore the client is getting more assistance than they would from either of our agencies individually. In Massachusetts, we have some state-funded short-term financial assistance. I hope that's the case in some other states at least as well. Legal assistance, I could go on for days about the benefits of having legal assistance in-house. But even if that isn't the case for your organization, I think that's a great opportunity to build a partnership with wherever your legal services providers are. Movers, we've established some really great working relationships with some affordable moving companies in our area, furniture banks, benefits programs, and again, really that connection between medical case managers, hospital-based social workers, advocates and community programs, just really bringing together what we are able to provide on the housing services side of things and the clinical expertise of providers and case managers really creates that cohesive model, hopefully, for the people that we serve. We also do a lot of work to try to help our clients maximize their income as much as possible. So benefits programs, certainly, and then also working with career centers and job training programs and being aware of those resources and referring clients whenever eligible. And then I would be remiss if I did not mention the importance of documentation and data and really looking at what our program is able to do and assessing, how we're doing and using that to inform where we go from here. Okay, that's the end of my presentation, and I think we'll have some time for questions.
Thank you so much, Kristen. I think that the Fenway housing program is such a fantastic example of what you're able to achieve by piecing together all of these different funding streams. I think it really speaks to the broader structure in our country with how housing is funded. I mentioned earlier in the presentation how housing is not funded as an entitlement. So you might be asking yourself, if this is the first time that as a participant that you're learning about how housing resources can be put together to build such a comprehensive program like this, it speaks to the way the system is structured intentionally, right? It's not funded as an entitlement. And therefore, we have special carve out programs for this subpopulation and that subpopulation. And then the burden is really on, a lot of times it's the individual, but then the administrative partners, the nonprofit partners, administering agencies to blend and braid these funding streams together in an often really complex way in order to make this happen. But this is really, this is really intentional because we continue to not fund housing as an entitlement in this country. So that I feel like that has to be sort of called out because Fenway has taken, I think, a lot of steps to make it as streamlined as possible for patients by one single application, limiting as many barriers as possible while taking on that burden of blending and braiding on the back end. So thank you so much, Kristen. I wanted to open it up now for questions from our participants. And you can feel free to drop your questions either using the Q&A function, the chat function, or if you're feeling particularly chatty, we welcome anyone who wishes to come off of mute to ask any questions that you might have from either of our panelists. I know I am particularly interested to know if any of our participants have similar, either similar approaches to how they are connecting their patients that are living with HIV or at risk for HIV to housing partners in their community, or if you have. Or if you have existing partnerships with other housing providers in your community to tap into some of the resources that we have talked about.
Kristen, I think someone is asking if you can share your contact information in the chat.
I just saw that. Yeah, I'll throw it in there.
Thank you so much.
I do see there was one comment in the chat about, with housing programs and a lot of potential partners and funding streams to consider when you're working on building housing connections in your community. And that is certainly true. And it's very dependent on the state and local area upon which you live. So Kristen went in detail about the level of federal, state, and then locally administered funding streams that she uses and that Fenway uses to build this program. And so starting to make sure that you're maxing out your connections for housing in order to support people living with HIV in your community begins with mapping out those resources in your community. If you are not already a member of your continuum of care, we certainly encourage every health center to do so, to start there, to join their local COC. It's a fantastic place to start making connections to the housing sector in your community. Excellent. Yep. So I do see a comment in the chat again from thank you, Lily, that we participate in coordinated entry with our local COC to connect clients who can't access our HOPWA programs immediately. Exactly. Your continuum of care is certainly the best place to start with those partnerships, and can certainly provide that backup. Because again, you can access resources such as permanent supportive housing through your local continuum of care. But again, certainly at Corporation for Supportive Housing, our internal data shows that less than a quarter of federally qualified health centers across the country have any connection to any housing providers in their community, let alone membership of their continuum of care. So, and do you see another comment? Would you mind sharing more about not only access to housing, but also quality of housing? So that's certainly, I wonder if you could, Maria, extrapolate a little bit more. Certainly, folks that are accessing housing through these programs, units that are being accessed with some sort of tenant-based rental assistance have to meet quality standards, have to pass inspection in order to use that rental assistance on that unit. But by quality of housing, do you mean housing choice? Do you mean overall housing stock? If you could just elaborate a little bit more on your question, that would be really helpful. So we have one more question. Many of our patients are challenged with stable housing, but since as an FQHC, we best connect them with our resources since the cost of a program for FQHC building is very high. How would you comment on this? I'm not really quite sure how to answer that question. Perhaps one of the other panelists could jump in. By all means, if you're the person who put the question in the Q&A box, if you'd like to elaborate a little bit further in the chat or maybe reword your question, we'd be very happy to answer it.
I wonder if the question is around kind of either connecting patients to local resources versus trying to build your own housing program and assemble the resources in the way that the Fenway has, and kind of the some of the challenges that may come with that for an FQHC.
Oh, certainly. You know what? I think that probably is what they meant. Thank you. So, certainly capital expansion and building, housing program yourself can come in many different forms. So Fenway has, it just explained how they sort of built out their housing portfolio. There's many ways that health centers can engage. Sometimes there are not, in most cases, we find that there are not enough existing housing resources in a community for health centers to refer their patients to and tap into. We know that waiting lists are very, very long. Subsidy is thin. And that's why we see such special carve-outs for housing eligibility. You have to meet these very narrow definitions of either homelessness or disability income and various capacities, because if we broadened that eligibility, then millions more people would be eligible for assistance that we simply do not have as a country. So certainly in the course of our work at CSH as an NTAP, we talk to health centers across the country who are recognizing this barrier in their communities to housing and have created partnerships to create new housing. And that's certainly not an option for every health center, especially smaller ones, but those that are our larger health center partners are certainly taking these steps across the country. And we have many examples of health centers that are adding new housing units to their communities to meet that need through a variety of partnerships. And we have a lot of resources actually at CSH in particular about new housing development and health and housing partnerships through capital expansion. And you can find those at csh.org/HRSA if you want to learn a little bit more about how you can add to the new housing stock in your community through capital expansion as a health center. You can also reach out to me, and we can do individual TA with health centers on this topic as well. I do see we have one more. I have another question. With housing high cost, how do you connect with landlords to participate in helping the community? So I think this question is for Kristen.
It is indeed. It's not easy. We have really needed to dedicate staff time and really look at how we designed certain job descriptions within our housing search program to say, like, really a key part of some of our advocates' work is engaging with landlords, and not just in the finding the unit and getting through the lease up process, but also being available if something isn't going as well as the landlord would like, and trying to intervene and support the client to help them retain their housing, and also to maintain that relationship with the landlords. In Boston, the COC, Continuum of Care, has been doing a lot of work in this area as well. So we've started to see some units identified, some landlord relationships identified through the Boston COC. And so I think there's a possibility that that's happening, and hopefully that's happening in other communities around the country as well. And I think really trying to find those landlords who have some experience with some form of rental assistance and cultivating those relationships. We, over time, have had a number of clients placed through some existing, landlord relationships. So that's been helpful. There is also a recently developed landlord incentive program, again through the COC locally, and I think different entities are doing similar things in other places around the country too, to financially incentivize and offer access to resources to landlords who are willing to work with people using vouchers or other forms of rental assistance to move in to their units. So it's not perfect, and there isn't some magical answer that I can reveal for you now. I wish that there were, but those are some of the things we've been working with.
Thank you so much, Kristen. I think the broader issue around landlord engagement is an ongoing topic, and it becomes ever more dire, right? Because folks have, even if you're able to get your golden ticket of a rental subsidy, you meet all the eligibility criteria, your name comes up on the list, we still see so many people whose vouchers expire before they're able to find a unit that meets the standard. And it's because of a broader unwillingness on the private market to accept vouchers, even though we know that that's illegal to not accept it. It's still an ongoing issue, which is why we see, why we see an instances of project-basing vouchers, so that some of these barriers can be avoided in certain communities where this is a really, really high barrier. That's how we work around it. And that's why we, mentioning the master leasing approach is another way that organizations work around these barriers, is by master leasing units under the services organization, and then subleasing them out to voucher recipients as a way to navigate around some of those barriers. But we have a very severe housing stock shortage in the United States, which puts greater pressure and ever growing need on landlord engagement. Because of just the overall shortage. And then finally, we had one question about undocumented families. And I see, Kristen, you're typing your answer in, but I wonder if you could also comment on that question as well. What resources are available?
Yes, I was not typing quickly enough. So HAPA, COC, other supportive housing programs don't look at immigration status at all. And then on the state level, again, I can only speak to Massachusetts. I know that's very limited. I'm here as an example, but on the state level in Massachusetts, we have some state-funded voucher programs and state-aided public housing. And for those programs, immigration status documentation is not required either. So trying to access federal public housing or a housing choice voucher is not going to be an option for someone who can't show federal eligibility for those sorts of housing programs, but supportive housing programs and some things on the state level are probably going to be your best options.
Well, thank you so much, Kristen. I would also like to thank Dr. Ard. Thank you so much for your presentation as well, and to everyone for their comments and conversation. You should have already received in the chat, there are links to the slides as well as a link to our evaluation survey for this session. All of our materials, recording slides, and everything can be found on our website for the population health management task force. I just want to thank you all so much. Our next session will be next week on Wednesday, March 20th.